to be showing the initiative on such a short interval, and really they had been really keen to support our educational activities, for us to be in touch with each other and also get connected with our community team as well. So we all do agree that we are undergoing a little tough time, even ever since the COVID-19 pandemic has struck. The teams has been a little bit disintegrated. Yes, we all are meeting through virtually, accord these using these platforms and all, but it's okay. We all are slowly and surely, definitely going towards the right direction and all as well. So coming to our topic, it is indeed important. That we all understand what about the complications. It's not gone are those days, I would say, in the early days of medicine when it was just trying to give symptomatic cure. So okay, there's a hypertension, there's a blood pressure problem, some give something, which brings it down. So no one was bothered about the mortality benefits, no one was bothered about the morbidity benefits and all as well. And especially in the recent times, we all will agree that we tend to follow what is called as a evidence-based medicine. It's not just like this that okay, uh, this is what is giving symptomatic relief, so give this. No, what about the evidence as well? Is there any evidence for that? Is it supporting that? And then we tend to follow that. So that this is what we will try to focus upon, and this is how we'll try to go in the coming few minutes. And I hope I don't uh, take your valuable much of your time, and we will try to keep it focused. So these are my disclosures and all. And so we all will agree that indeed it is there is an urgency to act upon the patients who all tend to have a high cardiorenal risk, including those patients not just with the diabetes or the cardiovascular risk factors, but also the ones with heart failure as well. And we do have data from the DAPA HF, which has been showing, or which has been showing literally a new path in the heart failure management. What it means for us and especially for our patients tends to be very important. And a lot of newer things has been coming up, newer updates, a lot of several new areas which were unbelievable, especially in the earlier times and all. So, for example, there are some new papers which I was discussing with some of our team members from the heart failure about okay, what about the evidence, for example, for the heart failure with preserved ejection fraction as well? So, what I mean is, a lot of interesting things are happening, and the future definitely looks quite a lot exciting. And our own guidelines as well, the NICE guidelines, or even the ones from ESC heart failure, they have already adopted, for example, the usage of dapagliflozin as well for the heart failure, which reduce ejection fraction, and understanding how the new CKD license and the DAPA CKD data can help improve the outcomes of our cardiorenal patients is important, because what happens is even with our renal team members as well, I do remember we do tend to have had discussions even in my clinic. um, his chamber is just next to me, so especially on Wednesdays. So we do tend to have sometimes some discussions and all as well. And when there's some data, so it really makes it even more interesting. So I think we all will agree that our heart failure patients not only tend to have a high risk of cardiovascular death, even when we'll try to look out for the unplanned hospitalizations, it tends to be quite a lot significant. Even when I do remember, so I'm also a graduate of London School of Economics with my specialization in health economics, other than my PhD in atrial fibrillation ablation, which I did from Maastricht University. So we also tend to look like, okay, what about the economical implications as well? Whenever we are trying to treat a patient, is it even going to benefit him further as well on these parameters? At least the hospitals are definitely bothered about all these data as well. So we tend to notice that there's a significant component of readmission, rehospitalization for such kind of patients. So definitely, this is something we all will have to consider. Even when we try to think on the parameters for the survival in men versus the women, if we will look over here, so for some of the common ailments like the cancer for the lung, for the colorectal or the bladder cancer as well, if we will try to look, of course, in the men and women as well, they tend to be similar. However, when we try to compare, for example, for the heart failure as well, it tends to be as malignant, in fact, as the cancer. So, as I was telling, is especially few decades back, we all will agree that we tend to have very less options. So even when we are trying to deal with any kind of treatment for these kind of subset of patients, and most oftenly these patients used to be discouraged. So for example, oh, we have a heart failure, so the options won't be much and all. Now we do have options, and evidence has also been supporting. In fact, in the not just the last few years as well, with passage of time, what has been happening is obesity, the overweight or the high BMI has also been increasing. The percentage of people with diabetes as well has been increasing as well. So this is just an example. In the last just approximately 5 to 6 years itself, as we can see, there will be substantial rise in such population. And we used to study, whenever you used to study medicine, I'm talking like more than 2 decades back itself, we used to say that having a diabetes is like coronary artery disease equivalent. So those patients with diabetes alone tend to have a significantly high risk, up to 5 times, for the development of heart failure. And unfortunately, what happens is most of them tend to be undiagnosed. There are tools available, but we are aware that there's a long pending waiting list as well. We are trying to do many more things, not just the biochemical parameters like the NT-proBNP, and also the imaging modalities as well, which is becoming more and more common and widely accessible. There is wider awareness as well. And in fact, once there's onset of the heart failure, there starts the another vicious cycle. The vicious cycle is of the heart failure leading to CKD, CKD leading to heart failure. Same thing even happens in the other comorbidities like the arrhythmias. So the arrhythmias will lead to heart failure will lead to arrhythmias, in fact. And again, those patients will tend to have a higher tendency to come back to the hospital to receive specialized care. So, to be able to understand the pathophysiology, how it tends to happen, so according to the risk factors which we all tend to commonly come across, is the coronary artery disease, the systemic hypertension, the valvular disease, or even the cardiomyopathies as well. They are the ones which tend to impact the left ventricle, in fact. And with passage of time, a lot of times people tend to ignore, like, oh, blood pressure a little bit going up and a little bit going down. What matters? It's okay, a little bit up and down is fine. No, it's not like that. So what will happen is those are the factors which will be causing those pathological remodeling, and that is where it is going to cause onset of the dysfunction. So, for example, left ventricular systolic dysfunction, diastolic dysfunction, and these are the things which will further manifest into the pump failure. And there is already a defensive mechanism. See, our body has a great defensive mechanism, uh, has a huge accommodation range as well. So, for example, if something goes wrong, especially in the acute phases and all, the compensatory mechanism tends to kick in. So, even for all these problems as well, something like a neurohormonal activation, so which tends to have beneficial effects in the short term. However, with the passage of time, they will start causing their own problems as well. So that is when those patients will be presenting to all of us in the form of like dyspnea, fatigue, even edema, and all will be happening. So it is important to realize the neurohormonal activation in the progression form from the risk factors from the asymptomatic left ventricular dysfunction to the symptomatic heart failure, and ultimately causing even death as well. So, what are we trying to focus upon? There are multiple uh, parameters which we try to focus upon, not just it's about the diagnosis, the treatment, of course, Similarly, we are trying to take care of the hospital admissions, and we are trying to improve the quality of life. We are trying to help them have a better life as well. So, um, the field of heart failure has never been so exciting except the last few decades, I would say, or maybe the last decade, if I can be a little bit biased. So there is still a stepwise approach even in heart failure as well, which can take several months, even typically like 6 months. For example, titration of the dosage is very, very important. So it's not just about starting the therapy, like, okay, some medication has been started, but we need to keep on up titrating as well to the maximum tolerable dosage as well. So we all will agree from our age old wisdom, like those starting from the ACE inhibitors, ERBs, okay, adding a beta blockers, okay, if all the offloading has been done, we can consider the other options, and of course, in the last decade, we also had addition of RNE inhibitors, and the recent addition has been of the SGLT2 inhibitors as well. Now there are some newer flow charts which has been added up and which is gaining really good wider adoption. So in the way of using beta blockers and SGLT2 inhibitors as the step one. So I did discuss with this flow chart as well with some of our colleagues in heart failure team. So the good part with this is the three steps of the addition of further addition of the RNA and even the MRAs as well can be achieved within 4 weeks, and then after that, of course, we can continue to focus upon the up titration of the dosage. Yes, even in the heart failure guidelines as well, Dapagliflozin has been added, and this is even in the ESC guidelines as well. So it is included as class 1A guidelines. So from the time of whenever we diagnose a heart failure, uh, we should try to, of course, first of all, offload them using diuretics. And after the classification between the heart failure with preserved ejection fraction, with reduced ejection fraction, we should always try to take care of the preventable reasons. So here again, the age-old wisdom comes as like prevention is better than cure. So if we can take care of the preventable risk factors like the hypertension, the atrial fibrillation, the ischemic heart disease, or even the diabetes as well, it's quite a lot helpful. Okay, and that is where we have to also help our patients to get a good personalized exercise based cardiac rehabilitation program as well, especially in the last few years. There has been a lot of awareness about the cardiac rehabilitation program. A lot of centers are also starting it up as well, and in fact NHS also has been making available some good amount of funding for the different centers to start up the cardiac rehabilitation program. So it is something really interesting. So yes, medical therapies is important, but also something like these things as well. And that is where we start to offer them our various medications and all. And still, if they continue to be refractory, that is where we may have to consider for the role for the device therapy, in fact. And yes, if they fulfill the criteria for that. One of the things what we all have to uh, keep on emphasizing is the sick day rules. For example, if we do come across these patients with the UTI or the genital infections and all, we have to counsel them about the risk which is associated. Similarly, so it's not about just like, okay, starting the medication. We need to also sometimes anticipate what could be the associated problem. So, for example, what about those volume depletion things and all? So, those patients need to be sensitized for that. And similarly, yes, we all will also have to keep it in our mind that SGLT2 inhibitors also they themselves can also reduce the glucose um, uh, levels of the serum as well. So if someone is on so already on anti-diabetic therapies and all as well, so we may have to consider reducing the dosage for that. So uh, it has been a wonderful journey, I would say, for molecules like this, which is being supported by evidence as well in the treatment of other comorbidities. For example, it was almost a decade back when it was established for the treatment of type 2 diabetes mellitus, in fact, and then later on, the data started coming up and all. I do remember at that moment I was working in Netherlands, in fact, and what we used to notice especially is a lot of our patients who used to be on SGLT2 inhibitors, uh, we barely used to notice heart failure symptoms. So even, for example, from the arrhythmia perspective and all, so if someone is on atrial fibrillation, if they will be having minimum heart failure symptoms and all, being diabetic, and if we interesting studies which is already coming up, and some of them which has been published, so it will be something interesting to look on those data as well from the arrhythmia perspective, if it can help them. And I must say the results, some of the studies has been pretty positive. Even earlier, for example, for the cardiovascular outcomes, there had been multiple studies like the Declare TIMI 58 or the EMPA REG outcome or the Canvas program or the Vertis CV as well, which showed significant cardiovascular benefits and, in fact, reduction in the risk of heart failure incidence as well. So, what I mean is, it has had a good history, especially in the last decade. And I think in the coming few years as well, it will be even more exciting to go through further about the data, where else can be the possible usages. Indeed, it is now therapeutically indicated for diabetes mellitus, heart failure, and chronic kidney disease, in fact, as well. So, for this, we should also understand that, in fact, it may also uh, have a influence on the downregulation of the sympathetic activity and tends to lower the preload of the heart and also the afterload of the heart, which tends to cause significant benefit. And we all know, I think most of our colleagues over here, they tend to agree, we all will agree that it not only reduces the glucose and sodium reabsorption, and that's what further leads to finally, urinary excretion of excess glucose and sodium, and that's where um, lies the importance of renal function as well. So whenever we are trying to start this medication, we all have to keep it in mind. What about the EGFR? So, for example, EGFR should ideally be more than 15. In fact, although when we try to look at the data which has come from the clinical studies as well, there's not so much of data, I must say, if the eGFR is less than 25 ml per minute, in fact. And so, of course, if there is a patient with less than 15, we should not use it at all and try to avoid it. And yeah, so we have to be a little bit extra cautious. Similarly, if there's a diabetic patient already on other anti-diabetic medications and all, so we may have to come down on the dosage. So, um, I think over here too, I will try to wrap it up. We all will understand the role of SGLT2 inhibitors has been on multiple parameters, not just to take care of the heart failure, but also is being indicated, of course, for diabetes since a long time. And the latest addition has been about the chronic kidney disease. And there are some interesting studies which are also supporting its usage in the other clinical conditions. I think we all can look forward to that. So, if there are any further questions, I'll be more than happy to take. Thank you so much. Hey, yes. So, you know me, you have seen me. So, what happens is I try to get hold of people, especially while doing the ward rounds and all. And of course, we tend to have our discussions as well, like, okay, what are the new things, what it goes around and all. So, in the last few weeks, I did have had discussion with some of the nephrology consultants and all, because they do give us calls for the referrals, and they do ask for our opinions as well. And so we do give them, share some of the updates and all. So it happens. I can also understand for them, they they I don't want to say that they belong to some different planet or something and all, but but what happens is, I think, see, diabetes and cardiology, they always went together, in fact. So kidney disease and all was a little bit far away. So that's why we had been much more open to the usage of dapagliflozin, for example, when we were able to see for the heart failure. So we were already used to it. So for them, I think this is something new, and they will have to understand. Like, look, the guidelines are there as well. Uh, Evidence is there as well to support this, and of course, on the practical grounds and all as well, we all are there as well to help support. And indeed, MDT is an excellent way to take care of complex patients, and also to discuss together as well, and also from the learning perspective as well. So most of the hospitals, they do tend to have this approach, and I have always supported this um, with any of our heart failure team members as well. Whenever we have had discussions, I did try to raise this issue also over here when I had, participated in a single department meeting, even with our managers as well. I'm trying to shake the pillars, but I think it might take a while. So let's see. Let's see. I'm pretty hopeful. I'm pretty hopeful. They all want to strengthen the department, the other subspecialties, and everything and all as well. And what I can say is I will keep on trying till we succeed. No, no. Yeah. 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 So, So, especially for the hospitalized patients, it always was a concern as well. So, whenever we were using those earlier approved medications, so for example, like the beta blockers, even the ACE inhibitors or the ARBs as well, I think everyone will agree that they tend to have their own contraindications, which used to make it a little bit more difficult for us, for example, not just to initiate those medications, even for example, like even our own junior doctors as well, they will be, or our own colleagues, like who wouldn't been having much of experience, they will be feeling not so confident, like how to start, like okay, what about the up titration, what about the side effects and all. Oh, it will also reduce the blood pressure, it will also reduce the heart rate, it will also it will be causing some other problems and all. Okay, it will be causing low energy levels and all as well. So for example, like beta blockers, so if there would have been someone in the, or like they will be having a lot of these concerns. So this has been one of the good things with the SGLT2 inhibitors is like uh, the side effects are not much. Most of them, yes, I think it can be managed well. And as you already said as well, very nice point, and which we already shared earlier, like about the up titration. I have come across even now. Sometimes the GPs will be writing, "Oh, why not from 5 milligrams?" And there we did have a colleague as well. I think you all will agree. So he used to start on 5 milligrams. So that was a little bit weird. So indeed, so let's try to stick to the guidelines. Let's try to stick to which is the data which is already available with us and all. And I'm sure we will be able to help not just our patients, their family members as well, to assure them of a better quality of life. And also, I think for our own team members as well, it will be not so much bothersome, I would say, in the future. For example, as I said it, so it happens those youngsters and all, even if not just youngsters, I would say a lot of men, I would say. So when they will be started on beta blockers and all, what about my sex life? Is it is going to help? It is it going to cause problems with that and all? So they really used to be bothered. So a lot of times we had to just them off for that. So these are some good things, at least I felt on the practical practical ways of life, I would say. Yeah. Hmm. Yeah. The- no, uh, no, the MDT approach has already been widely implemented at most of the centers, most of the hospitals, even at the DGH levels as well. And I am aware that NHS is trying to really get it through as well. I'm confident in times to come it will happen for over here James Paget as well for sure. But it might take a while. But I'm confident it will happen. Till that time, we'll have to do it on one-to-one basis. No, no, I will take care. We will keep on refreshing it in the neurons, huh? To till the time it gets till the time it gets hammered in, till the time it gets hammered in. That's why I said it, neurons. Till the time it there's a connection with the nephrons. Take care. See you guys. See you all. Thank you. Bye.